Hi, my name is Anita Rijneveld. I'm a hematologist at the Erasmus Medical Center in Rotterdam. And today I'd like to discuss whether about the question, does adding blinatumomab to frontline therapy improve survival outcomes for adults with B-ALL? Well, as we know, the most important prognostic factor in ALL is for sure MRD. And especially becoming MRD negative early in the treatment course is very important. We also know that blinatumomab is able to convert MRD positivity into MRD negativity and improve outcome. And with that in mind, we asked ourselves the question whether addition of blinatumomab to frontline treatment very early, which means already in prephase, might improve the outcome. And in our study, which was a phase 2 study, including patients up to 70 years of age with a dose reduction for elderly, we used blinatumomab in the prephase, after consolidation, and right before the end, before maintenance or stem cell transplantation. And what we found is directly after prephase, more than half of the patients was already in CR. So without any chemotherapy given, only steroids combined with blinatumomab led to a CR rate of 63%. And half of these was MRD negative. The primary endpoint of the disease was the MRD negativity rate, half of the protocol treatment. So after consolidation 1, including another blinatumomab course. And looking at that time point, all but one patient reached CR, and the majority, over 90%, was MRD negative. So indeed, adding blinatumomab very early to the treatment course is effective, leading to a deep response. But of course, how long does this last? How was the survival? So looking at that, we saw that the survival rates in Philadelphia negative ALL was around 50 to 80%, depending on especially age. So patients younger than 60 years were really doing very well, whilst older patients above 60 years of age, the toxicity was rather high. We used intensive chemotherapy, okay, dose reductions for these patients, but still, so that might have been the cause. But for younger patients especially, introduction of early blinatumomab, especially in prephase, resulted in a deep response and a better, so far better outcome. And if we look at the Philadelphia positive patients, we can see that in these patients, it was impressive because in the end, MRD negativity was virtually seen in all patients. And the survival rates were over 88% with 2 years follow-up. Impressive. And if we look at other studies done in this specific population, and if we look at the EHA 2022, Sabina Chiaretti gave an update of the D-ALBA trial. And the D-ALBA combined in Philadelphia positive patients dasatinib with blinatumomab. And now, with nearly 4 years follow-up, the results are still impressive. The survival rates after 4 years follow-up were 78%, above 75%. So that is long. A major concern in this study is the CNS relapse rate. But still, with a longer follow-up, still reaching such a high survival is really a good thing. Another study from Nicolas Short I'd like to mention shortly is the follow-up data with ponatinib combined with blinatumomab. And in this trial, he showed again that CR MRD negativity rate are high, and with a follow-up, median follow-up of 11 months, he saw a survival rate of 93%. So I think we must conclude that blinatumomab with lower dose chemotherapy than we have given in Philadelphia negative ALL, or even no systemic therapy in Philadelphia positive ALL, seems very effective and led to an impressive and deep response rate. And this holds real promise for reducing the proportion of patients who may need LOSCT. Well, thank you very much for listening.